So, welcome everyone to Conversations on COVID-19 webinar series. I am Hala Ali, the coordinator of Easter Alliance for Global Health Partnerships. In every webinar, we host experts from healthcare and global health fields to discuss various aspects of the COVID-19 pandemic, and we do those webinars, 2 webinars monthly. Today's topic is men and COVID-19. How are men affected by COVID-19 and how can the response better include them? A recording of this webinar will be available later on our websites, YouTube channels, and Irish Global Health Network and Easter Alliance for Global Health Partnerships. Live streaming is also available right now in our YouTube channel, Irish Global Health Network. If you have any questions during the webinar, please use the question and answer feature in the bottom of the screen. Before we move to the speakers and the topic, please let me welcome our moderator today, Niall Roche, Environmental Health Specialist and Assistant Professor at the Centre for Global Health, Trinity College Dublin. We are happy to have Niall as the moderator today, so welcome Niall, and the floor is yours.
Thank you, Hala, and I hope everyone can hear me. Thanks for that introduction, Hala. Great, and welcome everyone to another webinar of our conversations on COVID-19. And this is the 17th in our series. As Hala said, my name is Niall Roche, and I'm a member and a board member of the Irish Global Health Network. Apologies if you were hoping to see Nadine moderate as usual today, but she very kindly allowed me to guest moderate today on foot of the fact that I originally suggested we have a focused conversation on men and COVID-19. So I want to thank the Easter Alliance and the Irish Global Health Network for creating this space to have this conversation today, as it illustrates how all of us as members of the Irish Global Health Network can shape the agenda for other conversations and events that we have within the global health space. So if you have ideas, please get in touch. There's a lot of people I want to thank, but I'm not going to name them in any length. But thank you to Colin, Shan, Lauren, Bernadette, Louisa, Aidan, Bryn, Susie, and Aisling, who've helped to put this together today. I thank you sincerely. Just to say that we did try to get Global South speakers for today, but we found it particularly difficult. Now the time frame was quite short, but the speakers we have will be making reference to both local and global contexts in relation to men and COVID-19. So why have a conversation on men and COVID-19? As a global health professional, I know generally that a key indicator of health, though not the only indicator of health, is life expectancy or healthy life expectancy. Even in low middle income countries, life expectancy for women tends to be longer, and biological differences on their own don't explain that. Social norms and environmental factors play huge roles. In the context of COVID-19, men seem more susceptible to severe episodes of disease and more prone to death. Despite this, the general consensus view is that women, as in many other facets of life, are more vulnerable and more burdened by the direct and secondary effects of COVID-19. However, to date, I have seen personally little focus on men in the context of COVID-19, little discussion on the direct effects of the disease on men, little discussion on the secondary impacts on men, and little on how we engage with men to affect their own health and contribute to wider gender equity and equality. And some of you will know I tend to bang on a lot about this in terms of the balance in health. And I often inflict on my students a Depeche Mode song from the early 1980s called Get the Balance Right. Normally I'm banging on about the balance of curative care and prevention, or the balance in hygiene promotion within WASH programs, or the balance on key environmental determinants of health, such as air quality in public health programs. The question is, do we have the right balance? Do we have disaggregated data? How are men affected and coping? And how can the response better respond to the needs of men and boys in the wider gender equity and equality context? Also, how can the response contribute to other health-related needs outside of COVID-19 around sexual and reproductive health, mental health, damaging behaviors around smoking and alcohol abuse, for example? So let me stop waffling on and introduce our speakers today in the order in which they will speak. First up is Professor David Weekliam, who's Director of the Global Health Programme within Ireland's health system, known as the HSE. He's a specialist in public health medicine and has worked in global health for over 30 years, including 12 living in Nepal, Liberia, Sudan, DRC, and Ghana, plus 4 years as health advisor with Irish Aid. And he represents Ireland on the board of the Easter Alliance for Global Health Partnerships. David will fill the slot normally occupied by Rory Brewer to anchor the webinar. Next up will be Dr. Noel Richardson. Noel has extensive experience in the area of men's health at a research, policy and advocacy level. He was principal author of Ireland's National Men's Health Policy in 2009 and co-author of the first European Union report on men's health in 2011. He also collaborated on the WHO European Region Men's Health Report and Men's Health Strategy in 2018. His current research interests include monitoring the impact of policy and capacity building measures in men's health, men, masculinities and mental health, and health promotion interventions targeted at hard to reach groups of men in community and workplace settings. Next up, we are welcome to have Professor Maria Lohan. Maria is Chair in Social Sciences and Health at the School of Nursing and Midwifery in Queen's University Belfast in Northern Ireland, and Theme Lead for Maternal and Child Health. She is also a Fellow of the Centre for Evidence and Social Innovation. Professor Lohan's research team is dedicated to better understanding inequalities in health in society, especially in relation to improving men's sexual health and involvement in reproduction and parenting. And then the last speaker, but last by no means least. Oh, sorry, I've got to mention Gary Barker. Sorry, Gary is our next speaker. He's a PhD and is the Chief Executive Officer and founder of Promundo, an international NGO started in Brazil that now has 5 offices and works internationally to engage men and boys in gender equality and carry out research on masculinities. He's co-founder of Men Care, a global campaign to promote men's involvement as equitable caregivers. He leads the International Men and Gender Equality Survey, a study of men's attitudes and behaviours related to violence, health and fatherhood, carried out in nearly 50 countries. He has spent 20 years working in different parts of Latin America and currently lives in Washington, D.C. You're very welcome, Gary. And finally, but last but not least, is Professor Luke Clancy, who is the Director General of the Tobacco Free Research Institute Ireland. He's a consultant respiratory physician. He's an academic physician with an international track record in the area of smoking and health and on the causes, management and prevention of respiratory diseases related to air pollution, asthma, cancer and tuberculosis. He has considerable experience over the last 25 years in directing and coordinating research projects on these conditions. Numerous published reports, books and chapters and books on the topics of air pollution and tobacco control. So first up, I want to hand over to David Weeklim, who will anchor the webinar today. Thank you very much, David.
Yeah, thanks, Niall, and thank you for the opportunity to fill the role that's normally filled by Rory Brewer. And I think I can't do any better than to follow his tried and tested format. And I'll just say a little bit about the general situation with the pandemic and then a few remarks about the theme of today's webinar. So can I confirm that you're able to see the slides?
Perfect. Thanks, David. Go ahead.
Great, great. So this first slide is typical of what we're seeing on our updates that we get from the likes of WHO. This is from this week's situation report, or one of them. And what we see is the pandemic is just moving along unabated. At the top there, you see it spreading across the American region. In purple below is the Southeastern Asia, and that includes India, increasing. We see the peak has passed in Europe and Eastern Mediterranean, that's sort of in the middle, but there's still lots of cases and concerns about second waves and surges and spikes, etc. And then if you look further down in the blue, you see Africa. And perhaps surprising to us how it's been a bit of a slow burner. It's on the increase, but the pace not at the same rate as other parts of the world, but not reached its peak. So we kind of wait to see what will happen. It looks like it's some time to go before it will reach the peak. So in previous webinars, Rory has shared data from a number of countries. So I've taken that slide of Rory's and just updated figures just by way of kind of adding some comments to what's happening. And the countries we're looking at, particularly Brazil, India, South Africa, Kenya, and Ethiopia. And you see on the left there, the percentage increase in cases. And this is since our webinar, so the second last one, so the middle of June, so nearly 4 weeks ago. And you see the increase, steady increase in Brazil, over 200% increase, India, South Africa, over 100% Kenya and Ethiopia. So the pandemic is continuing to spread across these regions. Now we know if we look at the testing on the right, that amount of testing varies a lot between countries, so we have to interpret the case numbers with some caution. But if you look in the middle at the deaths, and you can see the pattern of deaths, and I've added in a column on the percentage increase in deaths, reported deaths, and you see there Brazil 55%, India 93%, and so on. So the deaths are increasing. There may be some lag between cases and deaths. There's obviously reporting issues, and clearly there's different impact of the virus in different populations. It's quite striking how Kenya and Ethiopia continue to have very low figures, even though the increases are significant. And if you look at the deaths per million population, still very low, 4 per million in Kenya, 1 per million in Ethiopia. So this is quite interesting to try and understand, well, what's happening in Africa, and how does that square with different stories we hear from what's happening on the ground? So we've reflected a bit on this in previous webinars, and that the issue of leadership has been highlighted, and as Forbes noted back in April, that countries with female leaders seem to be doing a bit better. I don't think anything has changed since. We've also remarked on the issue of social inequalities, noting that some of the countries most affected have high levels of social inequalities, such as South Africa and Brazil. But clearly many different factors at play, and it's a challenge trying to understand what's happening. And I'm going to share a couple of slides from data from this report that's just come out this week on Africa's varied COVID landscapes, and it's a report from the US, from the Africa Center for Strategic Studies. And it strikes me that Africa is quite hard to interpret. So for instance, we have one country with more than half the deaths, South Africa. We've countries with very, very few deaths. Uganda has yet to report a death from COVID-19, and they have over 40 million of a population. So what's going on? And what we see, of course, is that it's very diverse. And this report I found very helpful in trying to sort of unpack some of the diversities of countries. You can't generalize countries, regions, they're all different. This report, I think, quite helpfully looking at Africa, described how early in the pandemic, important factors were things like international exposure, the size of the urban population, the strength of the health sector. And then as through May and June, as the pandemic spread across all countries in Africa, internal factors became more important within countries. The size of the urban population, relative age of the total population, the level of press freedom. And they came up then with 7 different profiles by which they were to categorize countries. That may be a helpful way of trying to understand some of the differences in patterns of what's happening in countries, and maybe also to anticipate what might happen in these countries into the future. So just to talk about a couple of them as examples, and I would kind of encourage you to have a look at the report. These first group of countries called gateway countries. These are countries with high levels of international trade and tourism: Egypt, Algeria, Morocco, and South Africa. And these are characterized by high levels of high urban populations, large cities. They're characterized also by relatively high age. So the median age of these countries is nearly 10 years above the African average. And so, no surprise that these are some of the countries most affected, 69% of deaths, even though they make up only 18% of Africa's population. Then if you look at another group of countries, and these countries they're described as complex microcosms. So these are more countries with complex social and political situations, large populations, large geography, large urban populations: DRC, Nigeria, Sudan, Cameroon, and Ethiopia. And what we see in these countries is these are countries maybe with less stability, with quite an amount of conflict, with less press freedom, with some governance issues. They also have high populations, high urban populations. And so you might expect then these would also be affected a lot. And yet here you see 35% of Africa's population, but only 16% of deaths. So this is explained by looking at some of the factors here. On the left, you see age. These are countries with low age profiles, low level of international exposure. So this is maybe quite a helpful way of understanding some of the differences between countries, but also thinking ahead and looking at these group of countries with high risk in terms of governance and fragility, as you see at the bottom, due to large numbers of displaced people and internal conflicts. So that might be a warning that perhaps these countries are more at risk of developing high levels of transmission into the future, and something to be thinking about. So moving on from that then onto the theme of today's webinar, just to make a few overall comments and ahead of the speakers who will elaborate on some of these issues. But we do understand that men and women have different susceptibilities to the virus and different vulnerabilities as a result of both sex and gender related factors. And we also understand and see the different social and economic impact that COVID-19 has on men and women. It's notable the reporting is not great when it comes to gender, and this is back in May, only 40% of globally reported cases to WHO had age and sex disaggregation. And I don't know if that's improved since. But what's apparent, and Niall alluded to this, is that a lot of the focus and attention in terms of the gender impact of COVID-19 has been its impact on women. And that's very much reflected in, as an example, this report from WHO, an advocacy brief in May. So what about men then? And this is from the Global Health 50/50 website, which is very good gender disaggregated data available, which you can track. Looking at the countries that we already referred to, and you see that we have partial data in 3 of the countries, so it's not complete. If you look at the cases, you see it's mixed. In Kenya and Ethiopia, more of the cases reported are male as against female. The pattern is different in South Africa and Ireland, more cases in females. So maybe it's good to look at the deaths, and here you see a different pattern, and here the more usual pattern is more deaths, a higher proportion of deaths are male over female. Now Ireland is an exception to that at the bottom, and we can understand that in relation to the high proportion of healthcare workers affected, and also the high level of outbreaks among nursing homes where residents are more likely to be older females. But I think the column on the right is perhaps the most useful to look at, the proportion of deaths in confirmed cases and the male-female ratio. In other words, how does the probability or the risk of a male who gets COVID-19 dying compared to a woman? And in most cases, it's higher. And indeed, in this table, all 3 countries we have the data from, the males are more likely to die than females. So 30% more likely in Ireland, 50% in South Africa and Kenya. And if you look at the pattern globally, and this is from the same website, this is from the 55 countries with data. And if we look and see in which countries, of 50 of these countries, the men are more likely to die from COVID-19 if they get it than women. So that's a very clear pattern. So just about to finish up on a summary of that is that globally to date, there's a fairly equal number of cases in men and women. Men are more at risk of dying due to both biological and gender factors. And some gender factors are particularly important, particularly they're the top 2, risk of exposure, lifestyle factors, diet, smoking, alcohol, occupational factors, and response to disease. Men are generally slower to seek medical care than women when it comes to disease. And we saw that, for example, with the Ebola epidemic. So at the bottom there, just by conclusion, men with chronic disease, as we know, a big risk factor, men are at higher risk globally of chronic diseases due to smoking and alcohol. And globally, there's a greater burden of chronic illness in men. So I'm going to finish there and hand back to you now.
Thank you very much indeed, David. That's really, really useful overview of the pandemic generally and the more specific issues around gender. I'm going to hand over now to Noel. Noel, I'm just going to ask you, in terms of policy approaches to prevention and containment, do we need a more explicit focus on accounting for sex and gender differences, which is interesting in terms of what David was highlighting there back in May, that very little data is sex and gender disaggregated. Thank you, Noel.
Thanks, Niall, and good afternoon, everybody. Yes, I'm going to just pick up on some of the points that David has made there, and to reflect on the broader context of men and COVID-19, and essentially to make the case for a more explicit focus on sex and gender differences in order to inform public health policy and practice responses, and to examine what population groups of men have been most affected by COVID-19. And I think this is particularly relevant in an Irish context because Ireland has been the first country anywhere in the world to develop a national men's health policy. So we can demonstrate some proven track record in this regard, and there's no reason why it shouldn't apply to COVID as well. I will also briefly reflect on the wider impacts of COVID-19 on men and explore how a pandemic might potentially be a catalyst for positive change in men's lives and present opportunities for a reconfiguration of men's roles, which I think is also something, like, we tend to focus on the negative side, but I think there's opportunities here to take stock and reflect on kind of work-life balance issues in particular. So just to begin on the broader context, to make a couple of general points. I don't know if others find this, but in trying to make sense of COVID-19, I think it's easy to be overwhelmed. I did a quick look at PubMed yesterday, and there are now over 32,000 publications on COVID-19, and that's all in the space of a few short months. Not surprisingly, there are many inconclusive or contradictory findings in the midst of all these papers and publications. So despite this kind of tsunami of information, it's still early days and there's still a lot we don't know, I think. So that adds to the challenge of trying to respond appropriately to the pandemic. Understandably, the focus up to now has been on, if you like, dealing with the short-term impacts, the day-to-day challenges. It's even more daunting and frightening thing to begin to contemplate on the longer-term cost. And I'll say a bit more on that later. And just again to pick up on the point David was making there, I think it's also important to point out that this webinar's focus on men is really important, but it should not imply that there's some kind of binary choice to be made between the needs of men and women. Obviously, the needs of both are really important, and it's critically important that we account for sex and gender in our response, not to kind of adopt this kind of competing victims rhetoric that we sometimes see in men's health literature, for example. So I think focusing on sex and gender is where it should be, and from that building appropriate policy responses based on that, not on competing needs, as I said. So David has kind of covered some of the points I was going to make about the kind of sex and gender differences. I mean, there are some differences in the rates of the disease and in the death rates, both the prevalence and the death rates. And some of this is accounted for by, say, caring and health care roles, which are mainly occupied by women, and by greater testing, say. So that tells us a certain amount, but it doesn't tell us the whole amount. If we look at sex differences for a second, I think it's really important that we distinguish between sex and gender differences, because in my experience of 10 years of men's health training for service providers, this is something that often causes quite a degree of confusion. So sex differences could be, say, biological, hormonal, or immunological differences between men and women. So for example, estrogen may enhance the immunological response in women, whereas testosterone may act as an immunosuppressant in men. So that's a basic sex biological difference between men and women. And accounting for sex differences is really important. We also know that there are the other factors that are more kind of complex mixture of sex and gender differences. So David also pointed out that the prevalence of underlying conditions is higher in men. So things like cardiovascular disease, diabetes, hypertension, respiratory diseases, these are all more prevalent in men. So whether these are a function of sex or biological differences and a combination of gender differences, say, related to lifestyle factors and health behaviors is something we need to account for as well. So it probably is more the latter. It's a combination of both. There are also then more clear-cut gender differences. So if we look at, say, men's poor lifestyle behaviors, sorry, just a second. Things like higher rates of smoking, binge drinking, poor dietary habits, which may be a contributing factor to higher obesity levels in men. And there's a body of literature that covers how health behaviors are influenced by cultural and social norms that shape men's attitudes and behaviors in relation to their health. Similarly, in terms of preventive behaviors for COVID-19, males have lower rates of hand washing and use of face masks, for example, although again, not all studies have shown that, I should point out, Maria. And again, there's likely to be a gender dimension to this. So for example, younger men in particular often see themselves as invincible or impregnable to harm. It could also be that the rejection of public health guidelines could be an active expression of masculinity, men asserting their right to make their own decisions and not to be dictated by authority systems. So in a sense, what I'm saying is some some differences are basic sex differences that reflect biology. Others are more complex gender differences that reflect social and cultural norms and that are much more complex to deal with, but are no less important and are really important that we should account for them. Okay, I'm just conscious of the time, so just to move on quickly. It is really important to look beyond sex differences. Like in England and Wales, for example, black males are over 4 times more likely to die from COVID-19 than white males. So a key question is, what is it about the intersection of gender with other social determinants of health that put certain population groups of men at such a disproportionate risk of adverse health outcomes? So if we just reflect on, say, a case study in an Irish context, that of male meat factory workers, it's clear that the factors underpinning their vulnerability during the pandemic are highly gendered and reflect multiple and complex layers of disadvantage. These factors include low rates of pay, temporary work contracts, typically with a lack of union representation, living and working conditions in crowded or cramped spaces. And a critical point is that it wasn't until their plight reached crisis proportions that they began to be noticed in terms of COVID-19 responses. So in summary, therefore, the rather minimal focus on sex differences to date and the almost total lack of focus on gender differences means that policy makers and practitioners are ill-equipped to address health and social inequities experienced in particular by more vulnerable groups, including certain population groups of men. And a key point is that health inequities already experienced by vulnerable and marginalized groups of men are likely to be exacerbated during COVID-19. Because as I mentioned, the COVID-19 follows the same kind of social gradient in health. Last couple of quick points. In terms of wider challenges, I think any time of recession or unemployment, there's a spike in suicide rates, so we need to be mindful of that. There's a lot of disruption to kind of communities, especially isolated rural communities where the pandemic has maybe had more of an impact. And I think understandably, the government's response has been focused on economic matters. We also need to think more carefully about what kind of wider supports are needed for more vulnerable population groups. And final point, I mentioned at the outset, I think it is an opportunity to take stock and see how there could be a reconfiguration of men's roles beyond that of economic entities, ensuring that they have more balance in their lives. And not kind of defining men's worth around their ability to provide or their jobs, that self-esteem and their sense of identity could be shaped by broader factors. There's opportunities, say, for fathers at home and possibilities for assuming more caring and domestic roles. We've seen really interesting increase in volunteerism and those who answer the call to action in say, in rural communities supporting vulnerable elderly people, for example. What I would really like to see is a restoration of mehel, that sense of community spirit that may have been lost for a while, and that COVID-19 has maybe come back, brought us back into sharp focus again. So that's me done, yeah.
That's great. No, thanks very much indeed for that. That was fantastic. And I think it's really important that you stressed also that it's not a binary choice, that we're looking at sex and gender differences generally across the board. And I'm happy also that you mentioned meat plants there as well, because I think the workplace setting is also an important risky environment for all categories of people. And I want to maybe move on now next to Maria, because again, Noel, you mentioned there about behaviours and men's behaviours. I know this is an area that Maria is focused on. And I was reminded of you yesterday, Maria, when I was in a shop across the road. There were 3 construction workers from a building site down the road here going into the local shop to get a sandwich and to get their tea. And the shop worker tried to stop them at the door to say one at a time, and they wouldn't stop at the door. They all came in together, the 3 of them around the tea station, and they weren't wearing masks, which is now compulsory in Ireland to wear a mask in a shop. So I'm going to ask you, Maria, because your work focuses on examining men's adherence to public health guidelines in high-income countries, which obviously affects the protection of themselves, as well as others like me who was in the shop yesterday and who was trapped and couldn't get out. Can you tell us about your work in this area and what strategies did you find to drive up adherence to the benefit of all?
Yes, thank you very much, and hello everyone. Well, just a little word about the context of this as well, is that it came from a request from the UK government to look at a problem that they felt that they had identified in their daily and weekly polling, which was lower adherence by men to the public health guidelines. And if, imagine that is the case, what would you do about it? So we set about a kind of a two-stage methodology to examine this question. And the first off really was to figure out, is there really a problem, if you like? And so, as Noel has said there, we dived into some of those multiple thousands of articles that are out there on COVID and did a rapid review of the evidence simply on adherence. So adherence to public health guidelines. And there we did find inconclusive evidence in some ways. So there were some sex differences in relation to social distancing, a little bit poorer in relation to men. But there was fairly strong evidence that there was lower adherence among men in relation to hand washing in particular, which I thought would interest you, Neil. So then also there was some fairly good evidence that there was lower adherence in relation to isolation. So then we really wanted to consider, well, what would you do about it? So the second stage really was to do an expert workshop with a group of men's health experts, where Noel and Gary also joined us to examine strategies rather than go into the literature. What have we learned over the last 20 years in men's health behavior research on what could help us now? And the strategies that we came up with, if you like, was first and foremost this one about show men positively doing the right thing in the company of other men and others, if possible. So while we're acknowledging that there is a problem, and you heard it acknowledged in the US news overnight as well from the public health expert, it's kind of like, all right, but if you want to fix the problem, you actually have to focus on men doing the right thing and show them doing the right thing. And the second one really was, you can't be what you can't see, if you like, or make the adherence visible. Because a lot of the messaging that's coming out from governments at the moment are single messages like stay safe, stay well. But actually it doesn't give you a picture of men doing the adherence. And we probably need to visualize that adherence a great deal better. We probably also need to make adherence desirable. So, you know, what are all the positive elements of making adherence desirable? And again, not to signal out the public health expert from the US last night, but he basically said, you can have fun later, but would you hold off now, young men? And probably that's not going to work for young men in terms of giving them that message. It's kind of like, what is positive about making adherence desirable at the moment? What can you actually do for others at the moment? Now, we all know that behaviors are not just messaging, and really the whole thing really is about the infrastructural requirements around that as well. And we do find that in countries where wearing of face masks, for example, is mandatory, there is higher adherence than amongst men. So it should kick in more in Ireland in that respect. But it's a great deal more to do with it. And in a lot of high-income countries, and you know, in the UK, we've been very lucky in terms of the infrastructure that's been put in place to protect livelihoods, to enable adherence. But we probably need to follow that up much more now with legislation. And legislation especially specific to specific occupations. We know, for example, that male security workers are particularly at risk. Male taxi drivers are particularly at risk. Male care workers, for some reason, are more vulnerable than female care workers. So we need to put some legislation infrastructure, maybe specific to certain professions, in place to support this kind of adherence. The next, the other issues that we looked at were in relation to also, sorry, my notes have gone off now too, and I've lost my place.
Oh, no problem, Maria. When you find your notes there, maybe also.
Oh, one was actually, came from Noel's idea, actually, who was in the group, which was, he pointed out, this is the last one, in fact, use the science. He pointed out that men love to know things, and they love to know particularly numbers. So translating some of the numbers, and the example that he gave at the time was actually the Cheltenham Festival, which I know has a strong place in the hearts of most Irish people. And it was like so many people could discuss the statistics around the impact, the harmful impact actually that the Cheltenham Festival had made. So that was our last strategy that we came up with that can be generally applied to many of the areas, whether it's hand washing or track and trace or self-isolation. Thanks.
Thank you very much, Maria. Just for our overseas viewers, the Cheltenham Festival is a horse racing festival where horses jump over fences, and we love to beat the British at horse racing. Maybe I just expand it beyond the COVID-19 crisis, Maria, and just ask you, how can we use this current crisis to drive up gender transformation in health that could benefit both men's health as well as women's health? Do you have any discussion on that? You have a minute left if you can, please.
Okay, great. Well, Noel mentioned this as well, actually. But I mean, we know from the graphs that we showed that there is a real, this could really deepen health inequalities. But there are some silver linings that we're all looking for as well. And the first is that for the first time ever, there's been a focus on health over wealth for many governments. For a moment, there really was a focus on let's protect health over wealth. So in the UK, the PM is pushing out an obesity campaign. Now, you may not be Boris's favorite fan, but this is actually positive in terms of pushing out another campaign, health campaign on top of this, which can promote the question of self-care. Noel mentioned suicide. That's our greatest fear at the moment, that this crisis will deepen an economic recession and that we'll move into a higher spike in male suicides. But if we can get that message of self-care being maintained now, we could, be more prepared to prevent that crisis. Another one is in relation to the opportunity, I think, really around the gender-based violence, around the crisis in intimate partner violence that this has thrown up. If more men's organizations such as Promundo has been an absolute leader in this field, in terms of saying, let's take a crisis in gender and health and show how men can engage to overcome that men can be allies in these kind of gender inequality issues as well. They've done the same in relation to the gender inequalities in house care. Again, it's about taking that and then also giving the positive messages out. And there have been positive messages that men have been doing much more care in homes since COVID as well. So get that counter message out. What can men do to solve gender-based inequalities that impact on men and impact on women?
That's brilliant. Thank you very much, Maria. And I just pick up another point that you mentioned earlier on about visualizing adherence and making it desirable. I think that's a very important message to get across this afternoon. So I'm going to turn my attention now to Gary, who has to get up early. He's in Washington, D.C., and has, I think, been drinking some coffee to keep himself awake. Promundo, Gary, has worked extensively in evaluating approaches to promote a culture of care among men, and one of those is in Rwanda. Could you tell us a little bit about that approach and what you have learned and what relevance this has for COVID-19? And try and stick to the 7 minutes as well, please. Thank you very much.
Sure. First, thanks for including me, and I get to start off saying everything Noel and Maria said in terms of how do we build a culture of care. Promundo's been, as you noted, Promundo's worked in more than about 20 years for testing different approaches and how to scale those up in terms of engaging men, particularly around violence prevention, sexual and reproductive health and rights, HIV, and engaging men in care work. And I think we need to start off with some humility around how much in terms of health promotion approaches, engaging men and boys really have shown limited success, partly because we've been doing so much single messaging, whether that's been condom use or violence, or some single message sexual and reproductive health approaches. They really show little success unless we build it as a relational model. By that, looking at who's around men, whether it's the male peer group, female partners, others, the workplace, others who influence kind of which direction men go in their health-related decision-making. In Rwanda, we've partnered for more than 5 years on a fatherhood and couple training model. So what it is engaging men in through the prenatal visit is where we recruit. It's done together with the public health system. It's a 16-session model, 8 sessions with men by themselves, 8 with their partner. We're talking about a setting where the vast majority live in heterosexual relationships. Men are recruited during a prenatal visit and then invited to participate together with their partner. Sessions focus on couple dialogue, basic maternal and child health information, early childhood development, and men's own health. We have found in evaluating that with a randomized controlled trial model, a 2-year follow-up found more than a 40% reduction in men's violence against partners compared to the control group, increased contraceptive use, increased uptake of prenatal visits, and greater participation by men in care activities. We didn't include indicators on men's health, but qualitatively we heard reductions in alcohol use, and a similar model adapted more in violence prevention for DRC. We did find a measured decrease in alcohol use. What we found in our kind of theoretical model, building and looking at it afterwards, is that men's behaviors changed to the degree that they felt responsible for and connected to others. So particularly the more they felt connected to their partner and either the new child on the way or the new child born, and about third already had children, they perceived the importance of change, and that change seemed to stick. The other was peers. The sense that, you know, my male peers are watching me if I'm doing behaviors that aren't considered appropriate for men in my setting, particularly those related to care work and those related to couple dialogue. There's a lot of conversations in Rwanda that if you are seen as doing joint decision-making, if you're not dominating your female spouse, that somehow she has bewitched you. Or if you're seen doing care work, that somehow takes away from your honor as a man. And so the importance of doing that collectively with male peer groups, including doing these out of doors. Men told us they could do those things, but with the shades closed. But we said, well, the importance of taking them outside. So what we can find from that is that really, you know, kind of the obvious lesson that men's health behaviors are shaped in relationships with others. And so our single message approaches that assume kind of men as the locus of their own decision-making really miss the opportunity to promote a collective sense of care that can have, we've seen in this approach in Rwanda, and I believe in other settings, multiple impacts.
Thank you.
Yeah, that's the Rwanda one.
That's the Rwanda one, yeah. And we have about 3 minutes left, so I think you are going to talk to us about Brazil as well.
Talk a little bit about Brazil. Brazil's one of those handful of countries. I think we're at 5, and Noel will tell me of countries that have a men's health system. Brazil's had one for now, let's see, 99. So what is that? So it's got a few years of experience. It started out kind of prostate cancer prevention focused. And we've been an advisor working with them over many years to make it into an overall men's health look. As in the case of Rwanda, we started advising them on looking at where men were in the health system in terms of primary health care. Men often only showing up for tertiary care. In terms of primary care, again, the single largest place where you could find men was at a prenatal visit. So we've worked with the healthcare system to build a prenatal health protocol for engaging men that has an opt-out approach that if he comes to the visit, he is encouraged to come to the visit. That is a pathway into a general health exam for him. In the 50% of municipalities that are carrying out the program across the country, that's in Brazil's is a vast country that's more than 5,000 municipalities, about 80% of men are coming to a prenatal visit, and we're getting about half of those men to come for a basic health exam if they come in the door. So it's proven to be relatively low cost to implement. There's no specific staff designated for it. It's online training, making materials available, and trying to, again, change the notion that it's men's fault that they don't come to turn into how can we adjust the healthcare system to get it to come. And I think, you know, I guess as some final points on what do we learn from that in terms of COVID, we've also done some research, including in the UK, the US, Mexico, Australia, Jamaica, with a survey that we called the Man Box survey, looking at the extent among young men ages 18 to 30 of harmful norms around masculinities, and measuring across 7 indicators of harmful traditional masculinity, to call it that. We find really high rates of association between negative behaviors that come from the more you associate with those values, the more you're likely to binge drink, be involved in a traffic accident, have suicide ideation, bully, use violence. But the other thing that's really important to point out, and Noel touched on this, was how much men also find a sense of identity in those rigid, harmful norms around masculinity. And so again, we've got to think about the change, what we're offering young men instead, to shift away from some of these harmful norms that give them salience and identity, particularly with their male peer group. So I suppose to end, what I'd say is, In terms of COVID, we are gathering stories of men doing the right thing. Our Men Care campaign, which works in more than 40 countries, is gathering stories of men who are doing the hands-on care work and participating positively at home. And so I want to echo Noel's point there of we can point to the gaps, or we can find many, many stories that find men doing the right thing, and they almost always are in relational context. And I'll stop there.
With 6 seconds to spare. Thank you very much. I was thinking there, when you were talking about finding men who are engaging in certain behaviors, I was thinking about a concept called positive deviance that we would use in the context of health promotion and hygiene promotion. And I want to turn now to what you were talking there about the harmful norms around masculinity. And one of the issues that I felt might have been important in relation to the COVID-19 conversation was around the issue of tobacco and the harmful norms around tobacco. And as we know, the majority of smokers globally are male, and the majority of smokers who die are male, even though in some countries I know that is changing significantly. So I want to turn my attention now to Luke, who's going to talk to us about smoking. And Luke, I suppose the question is smoking of relevance to COVID-19? And if so, is there a gender dimension to it? Because there was some confusion maybe before that nicotine had a protective effect on people in relation to COVID-19, and maybe you might address that for us, please. Thank you very much, Luke. You have 7 minutes.
Thank you. Good afternoon, everybody. Delighted to have this opportunity. Any time to say a few words about smoking is a bonus. There are plenty of words to be said about smoking in regard to COVID. In general, we know how bad smoking is, and we know the terrible mortality. Actually, in this context, when you think of over 7 million deaths from smoking annually, and we have the world shut down because there's a half a million deaths so far from COVID. So this is kind of interesting, and I think it brings up the point that Maria said about for the first time, perhaps, there is a kind of a feeling that health might be as important as economics, and in some instances more so, or at least they have equal billing or need to be gathered together. So when you think of that, and we think of the effort that's been put in to do something about COVID, and the lack of effort to do something about something entirely preventable that could stop 7 million deaths. Now, there's all sorts of factors about the immediacy and the short-term and acute that make it different, but there is a comparison, and it's really shocking. And especially the exploitation of lower income and less developed or more dependent countries, where the industry has a free will to go and do their damage and to do their harm at a time when better off countries are getting more sensible. So we have this kind of terrible epidemic of tobacco, which we're not applying any resource, any substantial resource to do something about, and something that we could do effectively with a lot less resource than COVID has already cost. So I think if it helps people to rethink priorities, then that'll be one little gain from it. As you said, though, Niall, when you get to actually looking at COVID and smoking, of course it can't be simple. You know, unlike the virus that you have no one to talk up for, you have the tobacco industry who look at every opportunity to maximize their profits in the world and addict as many people as possible, even if it knows it kills half of them with its product. So everything that happens, they assess and see where the gain for them might be. And here it is the confusion around the fact that in some of the early reports, fewer people who had COVID were smokers. And therefore, could smoking be protective? Well, smoking is bad for you, so maybe not that, but at least something in the cigarette. And you had all this urgency about it. You had reports initially from Europe, from France and Cyprus and so on, looking at this with small numbers of patients. And in fact, in the big study in France, which is 345 patients, you find that like in a lot of other Western countries, a lot of European countries, healthcare workers were very high in this and had very high prevalence. And of course, they have a very low prevalence of smoking. So you have all these kind of issues which raise doubts. So I would say at this stage, we don't know enough to be definitive, except to say, well, we do know some things. We know smoking is bad for you. We know it causes many of the comorbidities that we know are associated with high mortality here, you know, like heart disease, strokes, cancer, chronic obstructive lung disease. These are products of smoking to a large degree. And therefore, these are the comorbidities. And some people strip those out when they look at the effect of smoking. So I think we do not know enough yet, but we do know certain things. And the prevalence or the incidence related to smoking is uncertain, even though there are data from the United States suggesting that even when you go to electronic cigarettes, that the likelihood in young adults, young men as well in particular, the prevalence of the disease might be twice as high in those who even use e-cigarettes. So leaving aside prevalence, when we look at severity, we know a lot more. There is no doubt that severity of COVID is related to smoking. And the number of people who go to ICU and the number who die and the number who have severe disease on presentation, all of these are strongly linked with smoking. And of course, as you said, Niall, in many countries, that's also linked with maleness or masculinity, or certainly with being male. So there is a big issue there around COVID and severity. And this is not surprising because we know that smoking damages most organs in the body, and particularly ones that are exposed on inhalation, the lungs, the trachea, and so on, the whole of the respiratory system. And then from there through the blood to the cardiovascular system, the skin, the hair, everything. So we know it damages these, and we know that smoking makes you more susceptible to other viral infections and to COVID infections. So it'd be surprising if it didn't also apply to COVID-19, and we think we know that it does. And we have experience from MERS and SARS to show that this was always true. So there's no doubt about that. So when we know that, it's can we do anything helpful about it? And I'd have thought that this was a huge opportunity for smoking cessation. I can't understand how there hasn't been more emphasis on it. Now, in fairness, most authorities say, and stop smoking. Now, that is not enough. It never was enough. And it's not enough with this present pandemic. But it is something that's cheap and that's effective. There are treatments, they're effective, they're cheap. And yet we've had almost nothing. Now, when in the survey in Ireland, for instance, they asked people, do you smoke more now that COVID is on and that the lockdown was in place? And the people said yes. 45% something said, yes, I smoke more. A smaller percentage, 19 or 15, said, no, I smoke less. But here was the opportunity to intervene. And people in their homes, everything is going online. Why isn't smoking cessation going online? Why are there not resources being pushed into this on a huge scale at a time when, you know, people taking up smoking, children, young people, mostly 14, 15, 16-year-olds, they're at home. Why are they smoking? Variety of reasons. We've heard people talk about peer pressure and gender, etc. But they're at home with their parents. So we have a great opportunity, and yet we've done very little about it. It has been mentioned, in case people say it has. But what has been done, what extra resources have been allocated, as far as I know, none in special. In fact, in many health systems, people who were interested in smoking cessation were pulled away to fight the good fight against COVID. Yeah, in the meantime, they could be killed by smoking, and nothing was to be done with it.
Thank you very
Well,
much, Luke. I hear you in relation to that. I have my own examples in overseas settings where people, environmental health technicians, were pulled away from testing water to work on other perceived public health priorities in those particular contexts, because that was perceived as more of a priority. I know you probably want to have more to speak, and I'm sure everyone else has more to speak. We have had a couple of questions come in. We've only got about 5 minutes left. A couple of questions that came in. One came in from Nadine herself. Would love to know if any of the panelists can speak about stigma and self-stigma in men related to COVID-19 and what could practically help. And then we have another one from Morgan Clark. Are there good examples of working with organisations like Men's Shed, or otherwise this might be more peculiar to the Irish context, to engage men in the community to promote safe health behaviours during COVID-19? I don't know if we have time really to answer those, but I'm going to ask each panellist to wind up or finish off with maybe a quick thought or a piece of advice as we close the webinar. So I'll go in order again. So Noel, if you have a quick parting thought for us, please.
Yeah, no, just to address the Sheds question. There's a really good program ongoing at the moment called Sheds for Life, which is a health promotion program directed at mostly older men in sheds. And my parting thought actually revolves around this. It's the need for partnership work, community capacity building, engaging with community stakeholders in a meaningful way, using co-design methodologies. That's the answer to getting good prevention programs and management programs in place. And Sheds for Life is an example of reaching what are so-called hard to reach or difficult to engage group, but the men in sheds are queuing up for it.
Great, thanks very much, Noel. In order from as I'm seeing on my screen. So David, do you have any parting thoughts to leave us with?
Yeah, I think today's seminar has highlighted so many vulnerabilities among men that have always been there, and they've maybe been brought to our attention in the current context. And I just would concur with what other panelists have said. Let's take the opportunity of this crisis to address some of these fundamental vulnerabilities to men's health, and to try and build back better in the future so that men's health will be improved as a result.
Thank you very much, David. Maria, any final thoughts for us? You can unmute. You're on mute.
Thank you. Well, on the stigma issue, I think that's very important to try and not further stigmatize any groups of men in relation to this, to bring out the positive stories, even amongst the groups that are mostly blamed around these issues. And more broadly, I would make a plea to kind of whatever gender inequality issue that we raise, whether it's in relation to domestic violence, male suicide, or tobacco control, to find ways to engage men to fight alongside women to address these issues, and to find the hooks that will really bring men into those. And fatherhood often is in relation to tobacco control as well. Thank you.
Thank you. Thank you very much, Maria. Gary, if I can turn to you, any final thoughts, please?
Yeah, well, I wish I was more optimistic, but my two home countries are the US and Brazil, where we've seen just, how a toxic masculinist view of leadership is really pushing us further into a crisis of care. And so, I do absolutely agree with Maria that the need to use fatherhood and men's connections to their households is one. But I'm, also really seeing the power of racial justice movements and the women's rights field to say we need men as part of this, and we need to be on the streets to counter and ultimately vote out these really, toxic masculinist view of leadership from the top. So both we need at the household level the examples of men doing right and breaking the stigma to say it's okay to need care, it's okay to be vulnerable. We need those at the very top, and we need those at the household level as well. So I was really encouraged to hear the examples from Ireland, giving me a bit of hope in the places where I sit most often do not look very bright at the moment.
Okay, Gary, bit pessimistic. Okay, I'll move on to you, Luke, finally, please.
Well, I think I go back to the leadership point, that adherence, and Maria's point. We need to see it, she said. We need to hear it as well. We need to hear it from our leaders, and it ties in with what Gary is saying. the places where leadership has really failed are doing really badly. So we really have to address that. And in our own countries where we have the chance to give the leadership and to get our priorities right, not to be dragged hither and thither with everything that happens, and stick to the important things, but show proper leadership in them. And this, I think, would tackle the masculinity as well, because they need to be given permission to do the things that are important here. And when they see powerful people disregarding any kind of effort, then they're enabled not to do things, or in fact, they're almost forced not to do things.
Thank you very much, Luke. We're slightly over time. Overall, I just want to conclude by extending my huge thanks to all of you for giving up so much of your time and your expertise to share with us today. I'm really, really grateful. I'm sure everyone else is really, really grateful. I'm going to hand over back now to Hala, who will close up the webinar for today. Again, thank you very much.
Thank you, Niall, for coming up with this really great topic. So thanks for moderating the webinar today, and thanks to our speakers for discussing this really important and interesting topic. We hope to see you again in one of our coming webinars. Our next webinar will be on the 14th of August, and the topic will be Global Governance Response to the COVID-19 Pandemic, Global Inequality and Poverty. Thanks to all the attendees for joining and interacting during the webinar. We hope to see you again in one of our coming webinars. The recording of today's webinar will be available on our YouTube channels, newsletters, and websites. Thanks again, everyone, and see you in the next webinar.
Thank you. Bye-bye.
Bye.
Bye. Bye.